Okay, hi everybody. Welcome back to the snapshots that we're doing for the See Big Screen project. Today we're deviating slightly from our earlier format in that we have a special guest. I'm delighted to introduce Dr. Caroline Mason Mohan. She's the Director of the Public Health in the National Screening Service here in Ireland. So you're very welcome. Thank you so much for being here.
Thank you, Vanessa. Thanks for inviting me.
We're delighted that you took your time out, very busy schedule to speak to us. It's much appreciated. I'll get straight into it. Can I just ask you just to briefly describe how does the cervical cancer screening work in Ireland?
Okay, yeah, well, our cervical screening programme is called Cervical Check, and it's been in place since 2008. And we had a big change there in March 2020, just as the pandemic was starting. We changed from a cytology-based programme to an HPV primary screening programme. So we have HPV testing, and then we have cytology used as triage. So if people are HPV positive, we do the cytology to see whether or not they need to go to colposcopy at that juncture in their journey, or whether they need to come back in 1 year, have another HPV test. If that's negative, they go back into normal screening. If it's positive, they then, regardless of the cytology is still done, but regardless of the cytology, they go to colposcopy at that point. So that's the actual programme, and it's available to women between anybody with a cervix, women and anybody else, between the ages of 25 and 65. We upped the upper age limit when we changed over to HPV. Under 30, the screening interval is every 3 years, and over 30, it's every 5 years. And that's one of the advantages that we've got out of the changing over to HPV, that additional, I suppose, reassurance that we have about negative tests, that we can have that slightly longer interval. So it's delivered by screeners who are mostly based in what we call primary care settings, so GP practices. So GPs do them, doctors, but also, and for many women, it's the practice nurse that does it. And we also have a number of clinics around the country that will be registered with us to do the screening. Once the screening's been done, if they need to go to colposcopy, we have colposcopy clinics that they go to. They're sort of streamlined into those, and then on, obviously, into whatever treatment they may or may not need after that. So I think that's most of the programs. Anything else you wanted to know about it?
No, that's great. Thanks very much. It's great just to get a bit of a context of kind of how it works in Ireland. And when it comes to the screening then, what barriers do you see that exist for more disadvantaged or marginalised groups?
Yeah, well, I mean, that's an area that we're really interested in the screening service across all the programmes. And, my role in public health, that's one of the key things that I've been championing within the service. And we've done a lot of work in that area. So I suppose there are many barriers that can exist across the whole journey, the whole screening journey, and some of them exist before we even have contact with the people. So the types of things, I suppose we've been doing a lot of work in that area, and I think fundamentally, to understand the barriers, you need to talk to the people who've got the barriers. So it's very easy to second guess what's the problem. And if you don't know what the problem is, you're going to solve the wrong problem. So we have a few layers, I suppose, of information that we get from people and how we do that. So we have each of the programs, and Cervical Check is the same. We have an access officer that people can contact, and if they have particular needs. So those are needs that we can respond to on an individual basis. And what we also do is we take the learning from that. So if there is a problem that seems a very obvious thing that we need to be able to deal with, then we'll do it. Or if we find a problem that is just coming up for a lot of people, then we deal with it. So the sort of things we've put in place on the back of that type of information are translated videos, working with Translate Ireland to translate videos across a number of languages. We have, I suppose, the we've also put stuff into Braille for some people. We've got easy read leaflets for people who have problems with literacy. We've really haven't got one yet for cervical check. We've got one for breast check. So the breast screening program, and we're working on the cervical check one this year. So those sort of issues around language and accessibility of information. All of our stuff is with a new process going to develop all our leaflets that involves patients and getting it checked for literacy. A company called a NALA approach is what we call it. I don't know what it is in Europe, but so that the literacy level is right. So we have quite a lot of work on that stuff. But as I say, I think there are also barriers pre-screening altogether, and some of that is maybe about what people expect screening to be and how difficult that might be for them. So we did a piece of work last year, a piece of research with the LGBT QI plus group community, and some of their difficulty is just that, as they describe it, the sort of heteronormative environment of the services that they go into. So they don't feel necessarily that they're welcome there, or it's not that they're not welcome, but they don't feel that comfortable. That it's all very, sitting in the waiting room with posters that don't really represent them, and then that whole assumption across the services that they're heterosexual. So we found that I think about 2/3 of them wouldn't have told their GP that they're gay or whatever. So that gets in the way of that consultation. It also means they don't necessarily get the right advice for themselves, and they then find some of those conversations, if they are out to their healthcare provider, that they get they're not very comfortable in those conversations, the healthcare providers themselves. So we've got a whole list of sort of recommendations around that to try and support screeners to have more comfortable conversations with people. So I suppose that's one example of that. Obviously, there's the issues around people who don't have a regular address. So we haven't tackled that just yet, but we're doing some work with the traveller community, who do tend to move around, and so that will be one of the things we're looking at, is how do we actually communicate with people when we send everything out through letters? How do we improve that? And we know there are electronic ways we can do that now. So we're not there yet, but those are the sort of things we're looking at. The other thing then, the other group that have difficulties are obviously people with disabilities, and again they have also highlighted to us that issue of, even before they get to screening, they've nearly been excluded because of the literature. But as I say, we've developed these easy read. I suppose, so mainly it's been about trying to understand what people's barriers are and then respond to them. And think about them across the whole pathway. And we do know that socioeconomic people in poorer socioeconomic areas have difficulty engaging with lots of things, particularly things that need a set appointment, and in places that they can't get to because of lack of transport, and all the sort of wider social things that affect all of their healthcare, but particularly affect their use of things that are preventative. So there's no real you're not feeling unwell, so there's no need to necessarily it's not the imperative today to go and to get that dealt with when you've got other things to do. So that whole sort of piece around that. And as well, just the way that we share that information and we get the information to them. We're looking at that sort of community development approach to working through healthcare, sort of people that are sort of peer support for people. So with the traveller community, that they're a very good resource to work through to make sure that the messages that we give are understandable and relatable for people, and so tailoring them to different groups. So that's most of there's plenty of barriers. It's the ones that come off the top of my head. obviously, yeah, language and understandability of information, and then access to actual physical access to the services, but also that general culture around whether this is something that they see as relevant to them and important to them. And we have found the differences between sort of older women and younger women. Older women tend to feel that it's a good idea to go and have screening, but it's not really for them anymore. So, they've lost the message along the way that it's still important to keep doing it. And whereas younger women tend to be more anxious about the whole thing and, don't want to know, or, to get over that barrier as well. So, plenty of things to work on to try and improve the uptake, but so important to do it because it's publicly funded in Ireland. The people don't pay for it. So they're entitled to it. And if we don't provide the services that they can use, then they don't have the chance to take up that right that they have to that service. And we know that our services, the outcomes and the improvements that we can make are so much improved by having everybody have a chance to use it. And what we don't want is to find that those that are more at risk don't tend to come because that increases tips the balance between the balance of risks from screening and benefits from screening. And if those that come are less likely to have it, of course, that they're less likely to benefit, more likely to have the risks, and it tips the balance of the screening. So it's really important to me in public health to make sure that we attract people from across the whole community to our services.
Great, thanks so much. That was very comprehensive and really plenty of food for thought. It's just interesting, like you say, the whole spectrum and everything from making it feel more welcoming and making sure that there is room for everybody, to then just the actually physical practical aspects of it. So definitely really interesting. A lot of food for thought. So just to say thanks again so much for taking your time. We know you're very busy, so we really appreciate it. And like I said, this has been really interesting and very valuable. So thanks so much. Thanks a million. Thanks, Dr. Mason Mohan.
It's my pleasure. I love to share the work that we're doing. So thank you for the opportunity.
Thanks so much. Talk to you soon again. Thanks.
Bye.